Management of retrosternal goiter, retrospective study of 72 patients at 2 secondary care centers. Via Auris Nasus Larynx. Publication date, available online July 12, 2018. Source, Auris Nasus Larynx. Authors, Keat Wong, Subhaschandra Shetty, Randall P. Morton, Nikolaos P. McIvor, Zheng. Abstract. Objective. Data pertaining to the outcomes of retrosternal goiter surgeries performed at secondary care centers, where thoracic surgery expertise is not readily available, is infrequently reported. Careful patient selection is crucial to avoid an unexpected need for a sternotomy during surgery. We sought to evaluate the surgical management of patients with retrosternal goiters treated at 2 secondary care centers. Methods. Retrospective review of clinical records and computed tomographic (CT) scans of 557 patients who underwent thyroid surgery at the departments of otolaryngology, head and neck surgery of Manukwa Surgery Center and Wannerei Base Hospital. Inclusion criterion was extension of goiter below the plane of the thoracic inlet on CT scan. Clinicopathologic features and surgical outcomes were recorded. Results. The prevalence of retrosternal goiter was 72 of 557 patients, 12.9%. All patients in this series underwent thyroidectomy transcervically. Dyspnea was present in 48 patients, 66.7%. On preoperative CT scans, the goiter was noted to extend beyond the aortic arch in 7 patients, 9.7%. Tracheal bifurcation in 5 patients, 6.9%, and posterior mediastinum in 15 patients, 20.8%. Malignancy was diagnosed in 8 patients, 11.1%, histologically. Postoperatively, vocal cord paralysis was temporary in 5 patients, 6.9%, and permanent in 1 patient, 1.4%. Hypocalcemia was transient in 10 patients, 13.9%. No permanent hypocalcemia, tracheomalacia, postoperative hematoma or patient death was reported. During the study period, 4 patients were encountered in the outpatients setting whereby the evaluation of their CT imaging demonstrated features deemed to be at high risk of requiring a sternotomy: primary mediastinal goiter, N equals 2. And inferior extent of goiter to the level of right atrium, N equals 2. These patients were preemptively referred to a tertiary center where thoracic surgery service was available and their data was reported separately. Conclusion. With careful patient selection, the majority of retrosternal goiter can be resected transcervically with minimal morbidities. Preoperative CT scan yielded useful surgical information. In the presence of primary mediastinal goiter or inferior extent of goiter to the level of the right atrium, surgery should be planned in a tertiary center where thoracic surgeon is available. Add tags, currently, ORL, medicine by Alexandros G. Sfakianakis,